Welcome to Men's Anonymous, the podcast where men can be vulnerable and open without fear of judgment. Your host, Daniel Weinberg, leads authentic and unfiltered discussions that explore the challenges and triumphs of modern manhood. Join us as we break down barriers, challenge stereotypes, and redefine masculinity. Men's Anonymous, a safe space for men to lower their shields and share their inner world without judgment.
Hi, on this week's show we kick off our Movember series. Movember is a global movement that runs each November to raise awareness and funds for men's health issues, specifically prostate cancer, testicular cancer, and mental health and suicide prevention. On this week's show, we go through the journey of prostate cancer with Keith, Men's Anonymous. All right. Hey, Keith. So good to have you on the show.
Daniel, thanks for having me.
Welcome, welcome. So, we are in the month of November, otherwise known in the men's health world as Movember, which brings awareness to such men's health issues as prostate cancer, being one of the biggest. And we're going to get you to really dig in to this whole prostate cancer space. But I thought I would open up by giving a little bit of factual information to the listeners. So on prostate cancer, I personally know very little about it. The most I know, and men around me, my peer group, know, is that once you get to a certain age, circa 50, they say you should start getting yourself checked for it, because as you get older from the ages of 50 up, the probability increases of men getting prostate cancer. What that means and the effects of it I have very little knowledge other than some brief conversations I've had with you, Keith, and really I think it's super, super important that men become way more up the curve on their knowledge with regards to this space. So the risk of getting prostate cancer: about 1 in 8 men will be diagnosed with prostate cancer during their lifetime, but each man's risk of prostate cancer can vary based on age, race, ethnicity, and all other factors. For example, prostate cancer is more likely to develop in older men. About 6 in 10 prostate cancers are diagnosed in men who are 65 or older, and it's quite rare in men under 40. The average age of men when they are first diagnosed is about 67. Deaths from prostate cancer. Prostate cancer is the second leading cause of cancer death in American men, behind only lung cancer. About 1 in 44 men will die of prostate cancer. It can be a serious disease, but most men get diagnosed with prostate cancer do not die from it. In fact, more than 3.5 million men in the United States today have been diagnosed with prostate cancer at some point and are still alive today, which I found a fascinating statistic. One of the things when you look up prostate cancer, what they talk about is the concept of overdiagnosis and overtreatment. And I really want to get into this. So it says, because of screening, some men may be diagnosed with a prostate cancer that never would have known about otherwise. It would never have led to their death or even cause any symptoms. Finding a disease like this that would never cause problems is known as overdiagnosis. The problem with overdiagnosis in prostate cancer is that many of these men might still be treated with surgery or radiation, either because the doctor can't be sure how quickly the cancer might grow and spread, or because the man is uncomfortable in knowing he has cancer that isn't being treated, which again is basically you can have it, and if you do nothing about it, nothing will happen to you, yet we make the mistake of jumping in and doing radical things like surgery, etc. And then you have the overtreatment. The treatment of a cancer would never have caused any problems known as overtreatment. The major downside of this is that even if a treatment like surgery or radiation wasn't needed, it can still cause urinary, bowel, and or sexual side effects that can seriously affect a man's quality of life. So there's a lot to get into. And I think what better than to speak to my guest today, who has not only experienced this firsthand, but decided to go down the deep rabbit hole of what this all means and became extremely well informed, so much so that he's written a book on the subject. He hosts a podcast on the subject. And we're going to get right into it now. And I think best to start with how that whole journey began. What did you have symptoms? Did you how did you even know that this was even an issue for you in your life?
Right. Well, again, Daniel, thank you for having me. A lot of questions you've raised and a lot to talk about. So how did I get into this? So at the age of 47,
That's young.
too young for prostate cancer. Don't worry about it. I was having a good time in my life. I was very fit. I was very sexually active. I had a wonderful girlfriend. And I was also a solo parent of my 2 children. And I had a Monday morning physical coming up, my annual physical. So because I was a solo parent of my 2 children, sole provider, I wanted to make sure nothing was going to go wrong with me. Well, the weekend preceding the Monday morning physical, my kids are doing sleepovers. So I get to see my girlfriend. I had chosen a lifestyle that I did not bring her into my house much, and I did do sleepovers. I did do sleepaways. Monday morning, I go get my physical and a lot of tests. This is all self-directed. And I come back with an elevated PSA, a value known as 20.4 nanograms per ml. I had no idea.
Okay. The PSA is done, from what my understanding is you go get a blood test for a PSA?
It's a blood test.
And in the bloods, there are markers that can show you whether there is a higher likelihood that you have, inflammation, infection. What is it exactly?
No, it's so as with all things we get checked with our blood, your glucose, your glycogen, your hemoglobin, there's a normal range. And if you are outside of the normal range, then it requires more investigation.
Sure.
That's all it means.
Okay.
It doesn't mean anything is wrong.
Sure.
Kind of the normal range is in low single digit numbers. And I came back 20.4. Immediately sent to a urologist. That urologist told me to prepare to be dying.
To prepare to be dying?
And I had, at that high of a PSA level, I had prostate cancer. So I'm 47 years old, sole provider for my 2 children. The mother's not really around. Who's going to take my kids? So we do a biopsy. Biopsy comes back benign. No cancer. I'm like, well, why have we just gone through all of this? So I started reading. And one of the things I read was don't ejaculate soon before you have a PSA test, because that activates the prostate gland. It can inflame it a little bit. It excites it, and your PSA value might go up. And you also read, don't read a bicycle or don't ride a bicycle. Well, my kids were away for the 2 days prior. So there was a lot of sex. There was a lot of ejaculation. And I was also a pretty big cyclist, and I had ridden double digits 2 days in a row. And also the morning of the physical. So I shared all of this with the doctor, and I shared with him one other thing. I said, I've also read about prostate stimulation. So my wonderful girlfriend would do prostate stimulation. So that's essentially a finger up the rectum. And you can stimulate the prostate and a greater erection and more ejaculate. And he just said to me how lucky I was. And we dismissed it right after that. I then had no sex. I didn't get on my bike. And 2 weeks later, we test the PSA and it's dropped all the way back down to normal. Fascinating. Okay, cool. I don't have to worry. This is the old man's disease. So let's take a moment and talk about the old man's disease and the idea that most men die with prostate cancer and not from it.
From it. That's very important.
First of all, keep in mind, you're dying from something else. If you hadn't have died from something else, you might well have died from the prostate cancer. The unique thing in the cancer world about prostate cancer is that it can be very slow growing. When we hear cancer, we fear. I'm 11 years since my diagnosis and doing very well. I'm also now dealing with metastatic melanoma. It progressed from my back to my liver. Now, that's a different cancer. Now, all hands on deck. Melanoma does not take long to kill. Fortunately, I'm in very good shape for my treatment. We may have it cured. Don't like that word, but we can sort of discuss it. But prostate cancer is this slow cancer. So I go back to testing periodically my PSA. And for 10 years, it goes up and it goes down. Goes up and it goes down. Every time it goes down, we're thrilled. And then there's explanations. Well, you might have an increased prostate size. It's growing a little bit. Might be slight irritation or slight infection. So it's kind of dismissed. And then I get the digital rectal exam.
Yes.
Just the finger up the rectum. Which
How
is
often are you supposed to have that?
Oh, there's no guideline. There really are. We throw out once a year because once a year sounds good for everything. And mine were always clear. You hear the word clear. So we're just going through 10 years of this. So this is from 47 to 57. Well, I'm now living over in England, working over there, and my PSA has gone back up again. So I'm thinking it's time to see a urologist. And I debate, do I fly back to the States or do I meet one here in England? And I had a friend who was a doctor, and I said, can you find me a urologist that's ahead of thinking? We did. I went and saw the urologist, and he says, we talked about my history and my fluctuating PSA. And he said, well, let's do a DRE. And I said, okay.
What's a what? Oh, what, sorry?
The DRE, the digital rectal exam.
Oh, yes.
Finger up the bum.
Yeah.
So I did what I had been doing for more than 10 years. I turn around, put my back to the doctor, drop my pants, and put my elbows on the table. You had one of these?
I've had it once before, yes.
Okay. The doctor laughs, and he says, you Americans. He says, take your pants off. He says, you're going to get up on the table. He says, I'm going to be here for a while. He says, you're going to get an erection because I'm getting a prostate massage. He says, we're going to bring your knees up alternately to your chin, and we're going to roll you left and right. He wants to rotate the gland a little bit, and he finds the lesion that had been missed.
Wow.
Turns out the doctor I had been seeing, urologist, for a good number of years, very small fingers. This doctor, very big fingers.
Wow.
So if you're getting a digital rectal exam, size matters.
Wow.
Okay? Think of that.
Yeah.
He found the tumor. We had missed it for the longest time. Then I start reading and I find out digital rectal exams miss most early stage prostate cancer.
Wow.
Well, of course, doctor puts on a rubber glove, gets some gel, goes up quickly. He doesn't want to be there. You don't want him to be there. You know, I want my girlfriend to be there for a long time, but you don't want the doctor there. But what's more important, the sexual achievement, or let's find this cancer early? So now at 57, I have a tumor.
Wow.
So the doctor in England says, we got to get you to an MRI. And I said, huh? Because, I got to do an MRI. Now, for 10 years, no one in the U.S. had talked to me about MRIs. We did them, but we don't do them. So I get my MRI, and sure enough, it's cancer. And then I go down the rabbit hole of how to treat. And all of the things you spoke about in the beginning, these words were here, I wrote them all down so we can cover them. Oh, it's going to affect your sex life. There's overdiagnosis. There's overtreatment. So let's jump into that as I'm 57, right? And the cancer was probably there for 5 to 10 years at least already. So this thing about it being...
Can they tell? Can they tell that?
By the size, yes. By how much it spread, yes. Because and mine was rated a low intermediate risk cancer. So that was probably an underscore. So then I was probably intermediate risk on the genomic testing that was done. So I'm intermediate risk, but mine had actually spread quite far, we came to learn. And this is at 57. So what perhaps...
Which is younger than I mentioned in the beginning that the average age they find it is 67, still very young.
Yes. Well, I'm 69 now, and let me tell you how I'm 68. Let me tell you how young 67 is. But let's take that for a moment, Daniel. Throw that out. Throw that out as an idea.
Mm.
Average means the average, the middle between the low and the high. We are not screening men on any kind of a regular basis. So if we screened all men, we'd find men in their 40s and their 50s with prostate cancer. That average age would come down.
Right.
Also, in that average is a lot of old men.
Right.
Men that are in their 70s.
It brings up the average.
Yeah. And they're not going to die from prostate cancer because they maybe have the 10 or 15-year prostate cancer disease and they've got 4 other diseases. So it brings the number up. So it's a very false misrepresentation of what's true. So men need to get that out of their heads. Okay. So I spend a year trying to figure out how to treat this thing because of all of
What are they telling you? What are the doctors telling you at this stage when they've done all this? Like you say, I've spent a year then working out what to do. It's like, aren't they telling you, hey, you need to get chemo, you need to get your prostate cut out? You're like, aren't they telling you what you need to do?
You hear everything. You hear everything. So after the MRI, I came back to the States and go meet with my urologist, man I'd been with for 10 years. And he says, I want to do surgery. He says, I have an opening next week. And I said, no. So I took a year from that point. Went back to Europe a couple times.
Can I ask you,
Mhm.
how are you physically and mentally feeling when you're told you've got this and you're not doing anything about it? Like, are you not sleeping? Is this occupying your mind all day, every day? Does it distract you? Do you feel lethargic, or are you not feeling any different?
Oh, I felt very different. I was angry
Uh-huh.
because we had missed it.
Uh-huh.
Deeply worried for my children.
Uh-huh.
And I had a wonderful life. And now that looks like that might end. And if you get into, well, it's the slow disease,
Mm.
if I've had it for 5 or 10 years, I've already taken a chunk of that slow time.
Makes sense.
And I did a quick dive into the drugs that are used for this disease.
Mm-hmm.
ADT, androgen deprivation therapy. So this essentially stops testosterone
Oh, right.
and raises estrogen. So I was a weekend athlete, a weekend triathlete. All of that's probably going to come to an end. Sexual activity is going to end. You're now going to watch chick flicks. Kissy kissy movies, as my granddaughter calls them. You're going to cry. I did spend a year on a drug called bicalutamide, and I didn't care for it at all. So
Well, what did that do?
it blocks testosterone.
Right. So does it make you feel weaker? Does it make you feel
Lethargic, weaker, your muscles shrink. The only nice thing I got out of it was really big man boobs. One of the ways I describe it, when I was on the drug for a year, I went up to the mountains and I was a campground host in this little campground up in the high mountains of the Sawtooth in Idaho. And every day I had this beautiful hike up to a place called Alice Lake. I didn't want to do it. I'd be on the trail and all I wanted to do was take a nap under a tree. And I was a triathlete, weekend triathlete, not a professional by any means, just having a good time. And I would watch chick flicks and cry. Genuine happens. Absolutely happens.
Wow.
And you put on weight. Anyhow, so we go back to this year where I'm trying to figure out what to do. And I'm afraid of surgery, which is the treatment I ended up having because of all the fear mongering. And so I went to Europe to look at some treatments that were not available in the US at that time. Those doctors, all looking at my MRI, said, your only choice is surgery. Now, you almost never hear this, but they're looking at the tumor location and they're saying there's not enough safety margin or space between your tumor and critical urinary bits, your sphincter valves, that if we try any kind of treatment, radiation, HIFU, we're going to hurt those parts. So your best chance is precision robotic surgery. So I ended up having surgery. And I will say that my continence improved because
wait. Surgery is not the removal of your prostate. Surgery is
that's the removal of the prostate.
the whole prostate.
The whole prostate's gone.
Okay. Now explain that whole story.
The removal of the prostate or afterwards?
The afterwards. What happens when your prostate is firstly, as we had in our early discussion, I brought up what my understanding of the effects of having your prostate removed. I understood was you had issues with your continence, with your bladder.
Mhm.
You had issues sexually. So I want to hear all about what are the actual when a man has their prostate gland removed, what can they expect as being some of the the resulting effects of functionality for the man?
Right. So what I want to do, Daniel, is take a step back
Yep.
and say, what are the risks or the side effects if a man treats prostate cancer? Our treatment options are surgery, radiation of various flavors, a variation of that being called focal treatment, focal meaning very localized. HIFU is one. I looked at that over 10 years ago in England. You couldn't get it in the US at that time. And the other one is the drugs. All of them can harm your urinary. All of them can harm your sexual function. Surgery will have the immediate effect. Radiation will typically have the slowest effect.
Mm.
The drugs can be fairly quick as well. They start blocking your testosterone right away. So if you're a healthy man and you decide to do the drugs and your testosterone is 900, it might go to 0 in a matter of a month or two.
That has a huge effect on a man to effectively remove one of the key ingredients of what makes a man a man.
That's correct. But what I want to say this for is this is what we need to understand. Treating prostate cancer has risks. Doesn't matter which one you do. We have all this anti-surgery focus.
Mm.
And we ignore the drugs and their effects. We ignore the effects that could come from radiation. So I went into my surgery, okay, it's my only choice, for longevity. So if I end up in diapers, I want longevity. If I end up with erectile dysfunction, I'll figure that out. I had had a decent sex life and I was willing to give it up. My focus was my kids.
Basically, your focus is ultimately choosing life.
Choosing life. And I wasn't focused. I was interested in listening to your chat with Leonard. He had a kind of a wild sex life. Mine could be in that category as well. I was like done with it. I wanted to live. I still had these 2 younger children and I enjoy so many things in life. I love the outdoors. I love to travel. So I went into the surgery with also an enlarged prostate.
What does that mean when they say it's like a bloated? What does it mean?
Bloated is fine. It just gets bigger.
Why? Because of what?
It's just what they do. I've not found a real scientific reason as to why and can we stop it. It's a gland that if you're sexually active at a high level or not sexually active at all, it's still a sexual gland.
Right. One of the readings that I come across a lot is that they talk about some of the things you should do in terms of preventing prostate cancer. And they say like ejaculation.
Bullshit.
Oh, okay.
Bullshit. There's no evidence. There's a lot of talk about what is scientific evidence. So let's you and I do a study. Okay. And let's pretend I don't have prostate cancer and let's pretend everything's healthy. So we're going to do a test, Daniel. We're going to do a study, you and I. So which one of us is going to stop masturbating?
Well, I don't masturbate. So you can do the masturbation part.
Okay. Which one of us is going to stop sex? Which one of us is going to stop?
Not me.
Okay. So how are we going to do the study?
Right. Yeah.
Okay. Really? We're going to choose you, Daniel, as a random participant.
You mean the control is very difficult to find the control?
Yeah, exactly. Right. So come on.
Yeah.
We're really not going to do that. And if we're going to do it with 5 men, the whole rest of the world is going to rely on the results from 5 men. So it's all garbage. It's cancer. Cancer comes. And so my enlarged prostate made urination more difficult.
Okay. This is what I want to talk about. This is what I'm going to do. The symptoms of like you knew because of the test, this PSA story, from the beginning of actually getting into it. There are a lot of men who doesn't get picked up. They don't know any of this stuff, but symptoms arrive. So tell me the symptoms that men can maybe be aware of, that if they experience them, they should really pursue a proper checkup on them.
Well, I think men should start screening with the PSA test long before there's any symptoms.
Right.
So I'm going to give you a patient answer. This is a non-medical answer in two parts. You don't want symptoms with cancer. Once you have symptoms, you're in trouble. When we found my metastatic melanoma last year in my liver, we stumbled on it because I was looking for prostate cancer.
Mm.
If I had waited until symptoms, my liver would be gone.
Mm.
If my liver's gone, I'm gone.
Mm.
So the symptoms that occur when the cancer leaves the prostate will be in your bones. That's pain. If it goes into an organ.
Well, what if it's isolated just in the prostate? What are you experiencing? Are you experiencing like your urinary flow is like you lose pressure? Like what are the things?
There's not a lot of indication that it affects urinary flow.
Oh,
But
okay.
so this is anecdotal from talking with other men.
Okay.
Doctors don't know. I will tell you that just prior to my diagnosis, a new girlfriend complained about my lack of ejaculate.
Okay.
Her concern was she wasn't satisfying me.
Right.
I'm like, no, this is great. Having a good time. You should be happy that I can go 20, 30 minutes, right? I have now learned anecdotally, talking to a good number of men, this reduction in ejaculate seems to be an indicator, but you won't find that in medical journals. That's about number one. The other one is, has the sexual drive or the ability of your erection come off at all? Most of the guys I talk to don't seem to have that. We seem just to see ejaculate dropping.
Libido not really affected, you
Not
say?
really. No, I had a high libido, but the prostate makes the ejaculate. That's its job.
Right. That's right.
Right. And I was having difficulty with that. Again,
Right.
I have to say it's anecdotal because the medical books won't tell you that that's an indicator. So you don't want symptoms.
Okay.
Symptoms are bad with cancer.
Yep.
So after my surgery, my large prostate's removed and I urinate fabulously.
You're not affected. But that's not the case for everyone. But you're saying
Well, no. And let's talk about that. There's a couple of things that we have to be honest about. So I have no doubt that a lot of the men that come out of treatment, let's say surgery, and they say, I have erectile dysfunction. Well, I bet you had it before you went in. You hear in the States on the radio, we do a lot of pharmaceutical advertising here. Half the men in their 40s will start to have erectile dysfunction.
I had a urologist on my show a couple months back, and that's a big thing.
It's a big thing. So all the men who have surgery were stallions before the surgery, and suddenly they're not. No, how about they maybe had a problem before the surgery, and now they're blaming it on the surgery so they can say, I'm a stud, it's not my fault. Right? Let's be candid about that. Urination. I'm going to be blunt here. Things I've learned. If you're obese, you probably already have urination problems.
Is it the bag for urination or?
Well, you carry one for a few weeks after surgery. That's not a big deal.
Right.
It's a catheter.
There's not men who have that ongoing.
Oh, there are some men. Some men lose their continence.
Right.
Some men do. So let's talk about, there's a gentleman I mentioned in the front end of my book. He lost his continence completely. His cancer had spread into his sphincter valves.
Oh, okay.
You want to get rid of the cancer, you're going to give up urinary function. What's your choice? Die with some good urinary function, die sooner, or wear diapers and live longer.
Right.
It's a choice.
Right.
Okay. So if the cancer's in the urinary bits, you got a problem. Good imaging will help the doctor see that, or the surgeon will see that during the procedure. If you have radiation, if the tumor is near the urinary bits, guess what's getting radiated? The urinary bits. They'll try and reduce the amount of radiation they get, but that's that safety margin that's in there. And again, when I was diagnosed and my doctors were looking at my MRIs, they said your tumor is too close to the valves. We can't get it with radiation because we need a wider margin to be sure we get all the cells. So I came out of the surgery fine. I
So what
recovered.
happens with your erectile functionality
I
post-surgery?
recovered in a year. Now, what I did not know 10 years ago that I wish I knew now, and it's being discussed ever so slightly, is particularly if you do surgery, but I also know men that do this that get radiation, is you get a penile pump.
Penile pump, not
Pump.
implant.
Pump.
Pump.
Pump it up.
Right. Yeah,
Right?
yeah.
Why? Because essentially it's a muscle and we need to work the muscle. We need to exercise the muscle. And now that you've done some damage to it, you
Oh.
really need to rehab it.
Does things like Cialis or Viagra help with that?
Yes, I now wish I had done that as well.
So
So the
explain. You're saying just having a low dose
low dose.
of
Because
those.
it affects the blood flow, which
Yes,
is what we need.
I think
So
that Brian Johnson guy, the guy is like the longevity addict. I think he takes about 2.5 milligrams of Cialis on a daily basis, something like that.
yeah, I don't do that, but I'm aware of people who do, and I think it's always worth looking into. But if you're post-surgery in particular, but I also know men that are post-radiation, which I also was post-radiation because that was my second treatment. I would now tell a man today having surgery, get your penile pump and get your Cialis or similar, low dose, and get into rehab of your penis.
What does that mean?
Rehab it. You pump it up with the pump every day.
You mean like literally put your penis on this pump thing and it's like just the standard penis pump?
Just think about it. Standard penis pump. Yep.
Oh,
Like what a porn star would use.
yeah.
Right?
Wow.
Exercise it. It's a
Wow.
different exercise than intercourse or masturbation. Right? And there are now therapists getting involved with this. They're learning about it. So that's the thing to go do. I know several men that have done it and they recovered within months. I took a year naturally.
Right.
And the recovery is good enough for intercourse, firm enough. Took a year for me. Woohoo, I did it naturally. Well, let's say I recovered at 87.2%. Maybe I would have recovered at 97%.
Understood.
Okay?
Yep.
So important to do. You shamed or embarrassed by it? Well, deal with that.
Yep.
Right? Right. It's rehab from surgery or rehab from radiation. After my surgery, I did not get all the cancer. It had already spread. Now, this is the game changer. So I contemplated for a year what to do, and I chose to do radiation to the prostate bed only. That's the space where the prostate used to be. And we had no imaging. We didn't, at that time, we're talking 8 years ago, have much of a way to look at it. We did the radiation, and we missed again. The cancer had already spread further than the field. Now, this is a intermediate risk cancer. Now, I'm talking about now being maybe close to 10 years in with this disease. So yes, it's slow, but I'm still in my early 60s. Young man. I still want to hike and bike and do all the things that I do.
Cool.
I tie in here some of the things that you brought up in the opening where we talk about the risk or 1 of 8, or they vary, or the average ages, or the number 2 cancer death, or 3.5 million men are still alive. So here I have now had my second treatment. I'm still alive.
So how old are you today?
Today I'm 68.
So you're 21 years in from the original PSA test you did.
Yeah, it could be. Yeah. I could be that long that I've had this cancer. So that's what's unique about it. That's what's also struggling about it. So am I overtreated or am I undertreated? What's the rest of my health outlook? Well, my health outlook's amazing. I don't have heart issues. All my other blood work is great. I'm now over a year into my immunotherapy, which is like chemo for my melanoma, and my blood work's amazing. I don't have any.
How do you feel? Sleep-wise, energy-wise, like how would you rate how you feel?
From the immunotherapy chemo?
All of it, from how you're feeling today with what you're currently doing.
I feel great because I look at all the men who are not great.
Right.
Compared to many men, I am fortunate. I am grateful. I am lucky. I can be tired.
Right.
I lack energy sometimes. And I'll go for a hike and I'll do 10 or 15 miles in the mountains.
Oh, wow. That's
But
big.
I lack energy. I'll ride my bike 50 miles, but I lack energy.
Right.
I do have to get up and go sometimes. When I started this immunotherapy for the melanoma, I can sleep 10 or 12 hours a day.
Right.
Now that's healthy. Everyone thinks it's good. But if you sleep 12 hours, that's half of your day.
Yes.
And if you take an hour to do all your pre-bed things, and then an hour after you wake up things, there's 14 hours.
You got 40% left of your day left.
That's all I got left, right? So that's quite impactful. There is the mental drain. It's not easy walking around with cancers. I do quite well with it. I keep a focus elsewhere. I keep a focus on my adult children. I keep a focus on my grandchildren. And I'm in the fight. I want to beat this. So after my radiation failed, now what do you do? Well, the standard protocols were at that time something called the Stampede trial, which is chemotherapy and the hormone blocking drugs. The side effects are horrid. Going to be worse than the surgery, worse than the radiation. And I didn't want to do it. So I found my way over to the Netherlands for imaging, something called a ferrotran nanoparticle MRI, and a PSMA PET CT. The PSMA PET CT was a new type of imaging, more sensitive. It was in trial in the US. So here I want to talk about a bit of misinformation for men worldwide. So it's in trial at 2 universities in California. Leading edge technology. Bullshit. They've been in use in Europe for a number of years.
Right.
But the US is like, look at us. It's like, that's crap. So I go over to Europe and I get the gallium-68 PSMA PET. I could not get it in the US. I applied for the trials and they denied me because they said my PSA was too low. They wanted to have success. So you hear a lot of men say, well, so this is after your treatments. You need your PSA to be higher. The PSA is now indicating cancer because you've been treated after you were diagnosed. So the longer you wait, the better the chance of the imaging finding the cancer. So let's wait until I have more of it? That's ridiculous.
Yes. That's counterintuitive.
Counterintuitive. But it's what the doctors will tell you. We need to wait. We need to wait. We need to wait. So I went over for this experimental imaging called a ferrotron nanoparticle MRI. It found multiple suspicious pelvic lymph nodes, suspicious in that it's not diagnostic, suspicious in that it's not a biopsy, but they are quite confident it's cancer. However, this gallium-68 PSMA PET, brand new in the US in trials at 2 major universities, didn't find anything. The PSMA PET is now standard in most countries, yet mine found nothing, whereas this other one found multiple, 5 to the count, pelvic lymph nodes. Came back to the US and they all said, well, okay, but we want to put you back on the Stampede trial, chemotherapy and ADT. And I said, no, I'm not doing that. So I found some papers about what was called salvage lymph node surgery. Now they go in and they take out the lymph nodes using the frozen section pathology method. Mouthful of words. Went to Belgium to have this done. Here I am an American going to Belgium. No one in the States will do it. I contacted many centers. No, we won't do that. We won't do that. The frozen section is they start with what they call the common iliac lymph nodes, take them out immediately. They're frozen and pathology is done. If cancer is found, then the surgeon knows what to do. We go for more. Every lymph node comes out, they check it immediately. If it's full of cancer, they keep going. Once they don't have cancer, then they go, okay, let's not go too many more. We don't need to take out more than we need to. Fascinating process. Left me in fabulous shape. That was 7 years ago now.
Wow.
7 years ago. Not done in the US, done in Europe, fairly common. I don't think of myself as cured. Once the cancer has sort of gotten out, it can be out in senescent cells,
Oh,
cancer stem
you
cells.
need to keep monitoring this, but like you just can have a really good period, basically.
Yeah, I've 7 years now.
So you went down the rabbit hole in your journey, just like rejecting what you're being told. The issue is for most people when they are in this situation is when they're at their most vulnerable, when they're at their most fearful. So they're going to take guidance from doctors and professionals and domain experts more likely than not, where you seem to have taken just I'm just going to be pardon my French, but I'm just going to be a stubborn asshole on this thing and just like, I don't care what you tell me. I know there's different answers out there. You're just not digging hard enough. And you
I
did.
I prefer, I wrote about this in the book, patient detective,
Okay, patient detective.
patient scientist.
So I want to know for the audience, I guess this is a good segue into, there's the book, which I really want to talk to you about, which is the sheep or wolf,
Yes.
which I want to understand, explain what you mean by sheep or wolf.
Yep.
And then and you've got the podcast series on prostate cancer. You talk about, what is the best resource for men when this thing drops? Where should they go? What should they do? But let's start off with sheep or wolf. Explain, like, when you built this title, what's your meaning? What's the messaging you're trying to get across when you're saying sheep or wolf?
Okay. So sheep are cute and loving,
Yes.
except sheep can be mean,
Mm-hmm.
but wolves are wolves. So we hear, oh, this is the good cancer. This is the slow cancer. Most men with it don't die from it. It's a slow cancer. What about the men who die? I don't want to be one of those. Well, that's the lesser number. Yeah, but it's 100% to those who die. So, an interesting statistic. When I was diagnosed in 2014, some 27,000 American men died from this disease. Last year, 35,700 souls. The death rate has been rising. Now, you hear advocates say, well, that's because there's more older men. Well, if we're accomplishing everything we're accomplishing, the death rate really should be going down a lot more. Now, it used to be higher 20 or 30 or 40 years ago, but we've come a long way. But I'd like to read something to you here that just came out the other day. And this will get back to your question. So this is from the Prostate Cancer Foundation. This is perhaps the biggest charity research firm in the world. This is their CEO. This is their ad pushed to me on Facebook. This is Gina Carather's president and CEO's quote. Through our efforts, which I translate to send us more money, I am confident that we are moving toward a future that's not today, where prostate cancer is detected earlier, treated more effectively, and ultimately defeated. So here's what she's saying. Send us money. We are not detecting it early enough today, and we're actually not treating it effectively. So be honest about it. So how did I become this patient detective, patient scientist? Well, go back to when I'm 47. I'm told I'm going to die. I get a biopsy, which isn't fun. And then I'm told I'm fine. And then I'm like, Doc, how come you didn't ask me how my sex life has been the last 48 hours? Why didn't you ask me if I haven't worked out a lot? Why didn't you ask me if my girlfriend does prostate massage? If you asked me those questions, I would have said, well, I did all of that. They would have said, well, chill out. Don't do anything for a couple weeks and we'll retest the PSA number, and it would have gone way, way down.
But shouldn't you do that anyway?
Yeah,
Shouldn't
but
they do that as a default anyway? That, like, once
yes,
you get tested,
yes,
you can have some false flags. Let's do it again in 2 weeks
yeah,
and see if
yeah.
you repeat it's like a simple thing to do, no?
Right. So that, Daniel, is the beginning of my going, what are these doctors doing here? What are these doctors telling me? And then when my urologist, who I had trusted, but had missed the tumor because his fingers were small and he did quick DREs and he never mentioned MRI to me, he had them available. He didn't do them. I become more untrusting. So that was the start of it. Then I go over to England, back to England, and the doctors there are entirely different. Now, here's a unique thing. So I had a company in England and I had employees and they were on the national health. And here in the US, we talk about all the harms of socialized medicine. I don't think the program's as bad as we think it is. I had provided my staff with private health insurance. So you see the same doctors. And the way I explain it to people is, look, under socialized medicine, the doctor works 8 to 5. They see so many patients. They don't see any extra patients because they don't get paid. But if the doctor wants to make more money, they now go into private practice. And after 5, you're nodding, so you know this. They took their time with me. They weren't pressured like we are in the US. We call it throughput. The doctor's got to see a lot of patients every day to get their money markers, right? They took time with me. They sat down with me. They looked at the MRI. And when you have a doctor who you're going to pay money to, private funds, tell you, don't use my procedure, I think you should do surgery. I had 2 of England's top doctors, one in radiation and one in HIFU, say, you need to go get surgery.
Right. Don't do my thing.
Don't do my thing. I'm going, But my surgeon, my urologist, he wasn't my surgeon, I fired him. He never really looked at the MRI and talked to me. He just said, let's do it next week. So then I came back to the States and there was a couple HIFU doctors here and they had to go out of the country to do the treatment. We couldn't do it in the US, go down to Mexico. But they're like, oh, we can do it. It'll be great. One of the leaders in the world said it wouldn't be great. But you're telling me it'd be great because I'm going to pay you privately to go down to Mexico and do this for me. And then there was another radiation technique that I looked at in England that was just beginning to be used here in the US. And that doctor at the Royal Marsden, a top center in England, said, don't do this technique. And a US doctor said, oh, it'll be great. I'm good at this. So further misinformation. Then I ended up doing the surgery. And then I find out after surgery, there's this great discussion about what PSA value you want to test. And there's something called ultrasensitive testing. And a lot of people don't use it. And they say, wait until you're at a PSA value of 0.1 or 0.2. And 0.2 is the US guideline, almost the international guideline for what they call recurrence. I go, how does it recur? My prostate's been removed. It was there. You missed it. But they want to use the word recurrence. So we're sorry to tell you, Daniel, your cancer has recurred. No, it was always there. We missed it. So that raised further doubts in my mind. Like, what is the theme here? Well, we want to put you on the drugs now. Okay, but I start doing deep dive into the drugs. And my daughter's a pharmacist and does some other things in neurology. And she's like, Dad, these are pretty serious drugs. This is what's going to happen to you. And I start talking to men who are on these drugs. Now, if you are, and I'm going to be kind of crude and rude, if you're an overweight couch potato, you may not notice it as much. But if you're fit and active, it's going to alter your life in a huge way. So that began to raise my doubts and my questions. And that put me into the patient detective, patient scientist. You got to choose your poison. This isn't an easy decision, but you need to choose it carefully and wisely. So the sheep or wolf, if this is a wolf cancer, if this is an aggressive cancer, I don't have much time. Melanoma, metastatic melanoma is a wolf.
Right.
Months to a year or 2 if we don't treat it. I had a sheep. I had a mean sheep, but it meant I had time. And when I found that out, so another quick thing. So this is early on in the first year of trying to decide what to treat. I learned in England of a test called genomic testing. What's that? Well, it'll give us an idea of how aggressive your cancer is going to be.
Right.
I talked to my doctor in the US. He's like, yeah, we do those. Well, we have them, but we don't do them. They're not approved. It's an American company. They're in use in England. Even under socialized medicine, they're in use, but not available in the US because it's not approved. I did it on my own. It got approved a year later, by the way, which is interesting. And that's what said low intermediate risk. I mentioned that first.
Yes.
But I turned out to be intermediate risk. Well, how'd that happen? Well, the genomic testing comes from the biopsy. We missed the worst bits. So I was underscored.
Right.
All right. So that changes things. So I had a mean sheep, which meant I had time. So for a year, back to your question about what did I do in that time frame, I wanted to do the right treatment. My focus became do this right. So I had time. But as I got to the end of the year, a couple of the doctors I talked to said, "You've had time. We think it's probably already escaped, but it wouldn't take much longer," became the advice. And I didn't, and I had it removed. So let's talk about overdiagnosis under treatment. How do we know? So here we are again, Daniel. You and I are going to be in this big study. We both have prostate cancer. So, Daniel, we're not going to treat you out of fear of overtreatment. Keith, we're going to treat you. Let's see how you both do. Sorry, Daniel, we should have treated you.
Yeah, that's again another hard thing to gauge.
It's a hard thing to
Only,
do.
only in Harry hindsight.
Right. So there is some indication now that some of what might still be called cancer, prostate cancer, and maybe it shouldn't be called prostate cancer. There's debate in this area called Gleason score. We don't have to go there. That's a debate, tricky area. Again, comparison now to metastatic melanoma, there's no doctor that suggests I should wait.
Right.
I found all these disparities on prostate cancer, and you can find them on the internet. You go Google away, you will find all these disparities. On melanoma, you have metastatic melanoma, we're sorry.
Universal.
Universal. Around the world, universal. Up until these immunotherapy treatments, you are going to die soon. Universal. Looks like the immunotherapy has worked well for me. It doesn't work well for everybody. But in prostate cancer, disparities left and right and up and down. What's overtreatment? So my cancer advanced to what's called the periaortic lymph nodes. My third treatment, that salvage lymph node surgery with the frozen section pathology. The periaortics are about as far as it can go. What sits next to those is the lungs, essentially. Right?
Oh, right.
Would my cancer have stopped there? Maybe. Maybe it was going to go there and stop because prostate cancer is not understood. It's not melanoma. Prostate cancer. It's not colon cancer. You have colon cancer, we don't wait. You have lung cancer, we do not wait. Prostate cancer might take 20 years to kill you. So maybe I was overtreated. Don't know. Maybe mine was just going to stop. I have a PSA level now on the ultrasensitive testing of 0.03x. The X meaning in the thousandths digit, my PSA value goes up and down. Doctors don't know what to do with this. You hear all these excuses. Well, it might be prostate cells left over. No, that was 10 years ago. It's not that. It might be senescent cells. Those are like sleeper cells sitting there waiting. Stem cells, cancer stem cells. It's a new area, the new horizon of understanding all cancers. They're kept at bay and we're not sure why. I don't necessarily care why. If they just sit there and I do annual imaging and I get annual liquid blood biopsies and nothing shows, so there's no evidence of disease, it can sit there and I'm happy as a lark.
Okay, so basically post having it removed, let's put the other cancer aside for a second. Do you have to focus much on prostate cancer related issues?
What do you mean by issues?
Well, it's been removed. The secondary cancer you have is a different cancer.
Different cancer.
You don't have any more prostate related issues anymore because it's removed, no?
No, I don't. Other than I don't have ejaculate, I do just fine.
Are you in a relationship now?
No. Last relationship was 5 years ago. I had a wonderful sweetheart in Europe, and COVID separated us. I got kicked out. I had my nice long stay visas, but I was told to leave. And then Carol came down with metastatic breast cancer.
Oh, well.
And I actually don't know if she's alive or not today.
Right.
She's a breast cancer specialist. That was her career.
Wow.
And it hit her very hard.
Oh, wow.
They had missed her cancer.
Wow, that's wild.
But hers went to her liver.
Wow.
And she withdrew. She withdrew to her 2 children.
Okay.
And I have not heard now in nearly a year. Respected her wishes. Broke my heart.
Yes.
And I've just sat quiet. So you do give up your ejaculate if you have surgery. You can't get over that. That's a big focus. And we talked about this briefly earlier. You did this great episode with Leonard, if you want to mention it. That was titled The Cliff. And he talked about having orgasms without ejaculate. Well, sounds crazy. But when you no longer can ejaculate because you don't have a prostate, but you can have sex, you still have orgasms. And Leonard did a really good job of talking about how,
That's interesting. So you still have orgasms just without the ejaculate.
yeah, and they're better.
Because?
Heightened sensitivity, heightened
Right.
awareness.
Interesting.
Leonard did, he spoke about, ejaculating into a dirty sock. I thought that was hilarious. So we all know what that means, right?
Yes.
We all, as men anyways, we get it. We understand it. We understand masturbation and we understand the ejaculating, wiping it all up. And if we get too focused, that's what we think the success is. And this is where Leonard talked about getting to a higher level. You get to a higher level. You get to a different sensitivity. You get to a different intimacy.
Mm.
It's a big change because
Yeah.
we measured it, right, by volume, right? If you're in your 50s or in your 60s and you had sex in your teens or your early 20s, maybe it's time for a different approach.
Of course.
Maybe
Absolutely.
it's time for a different experience. Maybe elevate your experience.
Yeah, totally.
And
Absolutely.
it's wonderful. And if your partner is like, okay, I understand you don't do this anymore and I'll work around it, then they can elevate their level of experience. It's a wonderful thing.
Amazing. Keith, so great to have you on the show. When I usually finish up the episodes, I ask a set of 5 questions, which I want to throw at you. So give me your just your natural response to don't try to overthink them. Don't overtreat them.
Okay.
Yeah. The first one is, who would you like to say sorry to given the chance?
That's a deep subject. That probably more than one person, but it would be my son.
Your son.
My son is in a bad place in life. He was born with very serious birth defects. I did my best to raise him. He struggles with psychosis and mental illness.
Mm.
And although I don't blame myself, I could have done a lot more.
What are you proud of being or doing in your life?
I'm proud of how I've taken care of my own health, and I'm proud of the information I'm trying to share with other men.
Which is amazing. When did you receive kindness while needing it most and expecting it least?
From Carol, former sweetheart. We met on a ski trip. I was sitting in the hotel lobby studying medical books. This is prior to my surgery, my first treatment. And she came over to talk to me, and she's a doctor. And she asked what I was doing, and I told her, and that started our relationship.
Wow.
And she
That's
was
great.
with me through all 3 treatments.
Wow. That's amazing.
Very amazing. A huge loss for me, but bigger for her.
Wow. What did your mother or father teach you that you frequently remind yourself of?
Not to live beyond my means.
Okay. And finally, what is your superpower?
This is interesting. So just a few weeks ago, I went to my 50th high school reunion.
Yes.
And it was a wonderful experience, and met some classmates and some boys I had admired. They all told me how much they admired me.
Wow.
And I didn't remember that. I didn't think that. And they said, you had so much self-confidence in high school. I'm like, I did? And it's my self-confidence.
Nice. Really nice. Keith, what a pleasure. Your energy is amazing given the journey that you've been through. And I feel that a lot of dealing with these major challenges in life, the response one has and the mindset that one applies to it has a huge effect on how they're dealt with and how you experience it. And from my discussions with you, I really feel like you have just the right mindset. Firstly, the determination to beat it, but also I think the ability to push the medical practitioners to do better. To like, no, there are other options. You're not digging hard enough. You're not looking at the options. You're not seeing what's going on here. And your patient detective, your sheer determination, I think has done you a lot of wonders. And it's something I think we can take a lot from So I just want to say thank you and giving us your time and sharing your story of the journey you've been on. So thank you.
Thank you, Daniel. My pleasure.
That's it for this episode of Men's Anonymous. Thank you for listening. For more information on the Men's Anonymous podcast, including resources discussed in the show, visit mensanonymous.com. Join us next time as host Daniel Weinberg provides a non-judgmental space for men to voice their innermost feelings and thoughts.